Thanks, Melissa. Thanks for the Cancer Council for the opportunity, and thanks for all the attendees as well tonight. It's always a pleasure to talk about physical activity and cancer. In a way, it's a kind of a new discipline, exercise oncology. And I hope I don't have too much heavy research data, and likely to have some possible clinical, practical applications for you at the end of the talk. So historically, clinicians have advised cancer patients to rest and avoid physical activity, probably similar to cardiovascular disease 50 years ago. Now, there's a lot of research data, probably 20 years of research data, a number of clinical studies suggesting that exercise is very important to prevent cancer. This is particularly for colon and breast cancer, and also to control a number of different cancers. And this work started back in 1986 at the College of Nursing at Ohio State University, where a lady, she was a clinical nurse with a team of clinical radiation and medical oncologists, suggesting that exercise at the time could potentially be a promising restorative technique for cancer patients. It was a fairly new concept at the time. So this was probably the first time that exercise science sort of merged with oncology, creating this discipline of exercise oncology. We have reviewed some of these studies, and Mary Winningham was the first one actually suggested exercise would have beneficial effects for nausea, for instance, and also reduction of body fat. This was back in 1988. Until 2004, there were only 26 clinical trials published in this area. The large majority of these studies was with breast cancer patients, and they are also using aerobic training, walking, cycling, running, as a form of exercise intervention to help these patients. Collectively, the outcome from these studies would indicate that exercise would be beneficial to reduce fatigue, improve muscle function, physical performance, aerobic capacity, body composition, not body weight, but lean mass and fat mass, and also improvements in quality of life. Now, we had some major developments in this area in the past probably 10 years, with the first really document being published and endorsed by the American Cancer Society back in 2001, which they spoke about nutrition and physical activity, but very briefly about physical activity. And at the time, there was just not enough research data. They suggested that exercise could potentially play an important role in survivorship. And then it went in 2003 up to 2012, more recently position statement that they highly endorsed physical activity with a prescription for cancer patients and survivors, not just to incorporate aerobic training, but also resistance training, which is very important to counteract the loss of muscle. And we'll talk about resistance training very soon. There's also an important document by the Exercise and Sports Science in Australia, which we had the chance to be part of this document in 2009. And the American College of Sports Medicine that set up a roundtable of clinicians and researchers from Spain, Germany, US, and Australia. We also talk about this document very soon. Now, there's a range of different opportunities for physical activity across the cancer continuum. We spoke about prevention, so there's a role here for prevention. Also prevention for cardiovascular disease, and this is very well known. Now, across the cancer continuum, exercise has now been studied, and physical activity, to facilitate recovery, rehabilitation, disease prevention, health promotion. For instance, patients with prostate cancer receiving testosterone suppression or hormone suppression have a higher risk of osteoporosis and cardiovascular disease. We also talk about this. Now, what's very exciting in this area, that apart from improving quality of life, reducing toxicities, and improving a number of side effects from treatment, there might be some, or there are emerging research data suggesting exercise might improve survival for colon, prostate, and breast cancer. We also talk about these studies. This is an example of reduction in toxicity with exercise. This is, in fact, a trial that we had here in Western Australia. Patients initiating hormone treatment for prostate cancer. This was published in the British Journal of Urology International. The title was Changing Muscle, Fat, and Bone Mass After 36 Weeks of Hormone Treatment for Prostate Cancer. So the therapy is very effective. It reduces PSA, which is the marker for prostate cancer, nearly 100% in only 9 months of treatment. Testosterone is also reduced, and that's the aim of the treatment. And what I want to highlight here, and that's what is interesting in our area, those patients are losing roughly around 1 kilo of muscle in only 36 weeks, and also gaining roughly around 2.5 kilos of body fat. The changes here are expressed in percent change, but those are the absolute values. So it's very significant. Those are prostate cancer patients, older adults, A lot of these guys already have sarcopenia. We are accelerating the aging process in terms of loss of muscle and bone with this type of medication, although it's very important for the prostate cancer. We also look at the role of that particular medication in reducing physical function and capacity. This is actually quite important because the loss of muscle is very likely to affect physical function and capacity, and that's what we have shown. Those guys have more difficult to walk, to stand from a chair, they have lower upper body muscle strength, and they have poor balance or a greater chance to fall and have a fracture. So what we decided to do, and this work was published in the Journal of Clinical Oncology in the US, was to run an RCT here in Perth. And this work was published back in 2010. Patients on androgen deprivation therapy, nearly 25% of those patients were also receiving radiation therapy. This was a RCT, which was a randomized controlled trial. We have an intervention study, which is the exercise study, and a control group, which is the group only receiving the therapy. So the intervention was a 12-week resistance, lifting weights, and also aerobic training program. The protocol won't go in detail, but moderate to high intensity resistance and aerobic training prescription, primary outcome lean mass, and I'll go with you in terms of some of the key outcomes from the study. So these patients that normally lose 1 kilo of muscle every 6 months or 9 months, they were able to reverse the loss of muscle. They gained 1 kilo compared to controls. They improved their muscle strength from 5 to 31 kilos depending on the muscle group. They improved their aerobic capacity. Here you're looking at a negative number for dynamic balance and aerobic capacity, improving their ability to do the test. They're reducing their time on that specific test, so that's improvement in outcome. And very important, they also improve their perceived health, self-perceived health in terms of general health, vitality, and fatigue, which is very important and clinical meaningful for these patients. In terms of some of the clinical data, no changes in PSA, which is important, indicate that exercise is safe, doesn't exacerbate the condition, and also no changes in testosterone. Now, these patients are also having experience with an increased risk of cardiovascular risk factors. This is an interesting paper in JCO suggesting that long-term androgen deprivation therapy leads to metabolic syndrome, which is the combination of some of these factors. In other words, risk factors for diabetes and cardiovascular disease. Nearly 60% of patients on long-term ADT will develop metabolic syndrome. We know exercise is very beneficial for diabetes and the prevention of metabolic syndrome. 80% of these patients will also develop abdominal obesity greater than 102 centimeters, which is a major risk factor for cardiovascular disease. Now, we spoke about risk factors. In fact, there are now some research data suggesting that ADT might also translate in cardiovascular events and metabolic events. For instance, this is a very important work published in 2006 suggesting that long-term ADT might lead to 44% of these patients developing diabetes. 16% will have heart disease and myocardial infarction by 11%. This research data is so important, so topical in the US and also in Australia that there's 2 important position statements that were actually published in the past 2 years. One endorsed by the American Heart Association, published in Circulation, titled Androgen Deprivation Therapy in Prostate Cancer and Cardiovascular Risks. And the other one, published in our Medical Journal of Australia, endorsed by the Endocrinological Society of Australia, Bone Mineral Density Society, and Neurological Society, highlighting risk factors associated with androgen deprivation therapy. Again, the drug is very important for prostate cancer, but leads to other issues and complications. And I'll show you some data here from Regano in the US, suggesting that 1 year of ADT leads to around 4.6% of loss of lumbar spine bone mineral density, compared to healthy men losing only 0.5%. And I'm going to show you some early data from an NHMRC-funded trial that we've been running for the past 2 years. We're reaching the final year of this study, and we have some very interesting data. We had 3 different intervention arms in this study, and I'd like to draw your attention from the resistance training and impact loading exercise. We actually had older adults jumping, of course, in a progressive nature, in combination with resistance training. As we know from the aging literature, this is the best exercise modality, mechanical loading, to maintain bone. Some interesting outcome from this study. None of these patients were on bisphosphonates, so they were receiving androgen deprivation therapy. The usual care group losing around 3% of bone over 6 months. Now, the traditional resistance training cardiovascular training group, walking and lifting weights only, still losing bone by around 2.5%. And for the first time, our group were able to show that high impact load in combination with resistance training without bisphosphonates can actually arrest the loss of muscle, which is a fantastic outcome. We're looking forward to publish this in the next few months. Now, drawing attention to other cancers, for instance, breast cancer, and I'll talk a little bit about this guy, Kerry Corner. He's a chair in Canada of physical activity and cancer, professor from the University of Alberta. This is a very large RCT done with 242 breast cancer patients initiating chemotherapy. So apart from leading to improvements in self-esteem, this particular trial, physical fitness, body composition, these studies show that women doing resistance training improve their chemotherapy completion rate. So we spoke about exercise following treatment. Exercise has a major role during treatment, and I'll show a little bit more research data. This research is particularly important, showing that patients might be able to tolerate the actual medical treatment if they are more physically active. Talking about lymphedema, I think we spoke about lymphedema earlier. Traditionally, women with lymphedema secondary to breast cancer were advised not to do anything with their arms in terms of resistance training exercise. And those are two very important studies by Professor Katie Schmidt, which, by the way, will be here in Perth with us on Monday. She published on the New England Journal of Medicine, which is one of the most prestigious medical journals in JAMA. The first study was weightlifting in women with breast cancer-related lymphedema. The second one, weightlifting for women at risk of developing lymphedema secondary to breast cancer. And the interesting outcomes from this study are, from the New England Journal of Medicine, for women with established lymphedema, resistance training, contrary to what we thought, decreases the incidence of exacerbation of lymphedema, reduces symptoms of heaviness and so on, and also increases function and muscle strength, which is very important for women with breast cancer. The JAMA paper, this was a cohort of women at risk of developing lymphedema. Contrary to what we thought, weightlifting or resistance training compared to no exercise did not result in an increasing incidence of lymphedema. So very important two studies, and I think we're going to be hearing more about those studies in the next upcoming years, which are changing clinical practice and guidelines. Another interesting study in lymphoma patients, also done in Canada by Professor Kerry Corner. First well-done RCT trial with lymphoma patients, either receiving or not receiving chemotherapy. What I want to highlight here, patients on chemotherapy undergoing aerobic training improve their VO2, cardiovascular capacity. It's a very important predictor of mortality. On the other hand, the group not doing the exercise actually reduced their capacity. Patients that were not on treatment, sort of a similar pattern for patients receiving the aerobic training program, improving their capacity, the other group not making any change. So the outcome from this study with lymphoma patients, exercise is safe, beneficial, leads to a range of physical and psychological improvements in terms of quality of life. Now, what's very exciting in this area for us is that there are now very large epidemiological studies publishing probably in the last 5-10 years, suggesting that exercise is not just beneficial to offset side effects and improve quality of life, but might improve survival in the long term. This is the first study that was published with breast cancer women, titled Physical Activity and Survival After Breast Cancer, a follow-up study in JCO on colorectal cancer, and another one in JCO last year with prostate cancer. So the outcome from those very large epidemiological studies, here we're talking about 20 years follow-up prospective studies, a protective effect in terms of recurrence and cancer death by 50%. It's not 3, 2, or 5%. It's actually 50%. Now, those trials are observational studies, not RCTs. There are RCTs on the way to confirm those very exciting results from those large studies. So, which is very exciting for this area. Very briefly, I probably want to point out this document that was published by the American College of Sports Medicine. This was a position statement. We were weighting the evidence of quality in terms of science of the studies, overwhelming data from RCTs, and as you go lower, similar to the NHMRC scale D, you have insufficient data to sort of show anything in terms of the science and the evidence-based data that is available. For prostate cancer during treatment, patients receiving ADT and radiation therapy, results from 12 RCTs. Exercise is safe, exercise improves aerobic fitness, Exercise improves muscle strength. Exercise improves fatigue, body size, quality of life, and physical function. Very similar to breast cancer, those are 22 RCTs during treatment, not after treatment. The evidence is A, for safety. Aerobic fitness is also improved. Muscle strength, fatigue, body size, quality of life, physical function, and also anxiety. So those are the results from 12 RCTs. So the final outcome and the final message from this document, hopefully from this talk, that exercise is safe during and after cancer treatment, leads to a range of improvements in physical function, quality of life, and cancer-related fatigue. There's a lot of interesting data now suggesting that exercise might have implications in terms of survival, which is very promising for colon, breast, and prostate. Now, patients should be following physical activity guidelines, also not very different from the general population. I will talk about those, which is accumulating 150 minutes of physical activity a day. Of course, with some adaptations based on disease and treatment-related side effects and adverse effects. For instance, patients with metastatic bone disease might need a different program than someone with a local disease. And I guess the final message here is to avoid inactivity. So being physically active, it's very important. Exercise Medicine Australia was, and I'll talk soon about this, it's a movement, it's actually a global movement coming from the US, Europe, and Asia, now in Australia. And recommendations that we have for physical activity for the general population is, and you'll be very familiar, it's 150 minutes of physical activity 5 times a week. Those are for patients or for anyone under the age of 65. Or if you increase your intensity, you don't need to go up to 150 minutes. You can do 60 minutes of activity or more vigorous activity per week. For instance, playing tennis 3 times a week. Now, plus resistance training that we also forget. Resistance training is very important, particularly for older adults. Resistance training might be even more important than aerobic training because you have to stand up to actually walk or run or go for a swim. So it's very important to incorporate resistance training in combination with aerobic training. And for older adults, also have some following balance exercise, which is very important for falls. And you probably heard about having a physical activity plan, or instead of taking the elevator, I'll go through the stairs. It won't substitute the cardiovascular prescription of exercise. This is also important, but it doesn't substitute the resistance training session, so it's a complement. As I said, Exercise Medicine Australia was actually launched on the General Practitioner Conference last year in Sydney. We had Professor Stephen Blair from the US talking about physical activity in the general practice. And one of the aims, there might be 2 ambitions, I might agree with you, Exercise Medicine Australia is to encourage GPs and allied health professionals to make physical activity or exercise assessment as part of their interaction with every patient at each visit when appropriate, even if it's 20 seconds or 30 seconds. Also with physical activity, patients want to hear from their doctor, you need to be active, you need to do something. The message is different than when it's coming from a researcher or from an exercise physiologist. The website has been developed. I'm not sure if I actually added to the package, but Exercise Medicine Australia, I think it's exercisesmedicine.org.au. A number of fact sheets, I think there's probably for 20 different conditions. So you have very simple messages about the role of physical activity and exercise, the type of prescription, and for instance here I'm showing some examples for breast, prostate, depression, exercise, and cancer in general. Now, if there's no time, there's also other alternatives. ESSA, Exercise and Sports Science in Australia, has a website that you can find an allied health professional specializing in exercise, which we call the exercise physiologist, which is a 4-year university qualified exercise physiologist. In Perth, we have 5 universities offering this degree now, ECU, EWA, Notre Dame. They all have qualified exercise physiologists coming through their degrees, which is fantastic. We're going to have more people trained to work with cancer survivors. And this is under Medicare. I think it's 5 consultations per year. It's not much, but it's certainly a start. The Cancer Council of Western Australia is certainly providing a very important opportunity for cancer survivors and carers. This is a free 12-week exercise program. There's a number of different sites. This is a very old pamphlet that I used last year, but from 2012, there's a number of different programs. I think every 4 months there's a new program running in different sites across the city, and it's evidence-based program. I'd like to acknowledge some of my colleagues. This is a very multidisciplinary team. We work with medical oncologists, radiation oncologists, urologists, psycho-oncologists, here from Perth and also from other states, and also competitive research fundings that we have been receiving over the past 8 years. Thank you very much for your attention. I probably want to highlight our clinic at ECU. We have probably close to 100 different GPs referring patients to Alive Health Service that we have for clinical psychology, physiotherapy, exercise physiologists, and nutrition. So it's fantastic. You guys are doing a fantastic job. Thank you.
Thank you, Daniel. We have some time for some questions. So if anyone has a question for Daniel, we have a microphone going around. So just raise your hand, please.
Are you able to see the different exercises, walking, running, swimming and circuit training gymnasium for senior people?
Oh, it's certainly very important. Aerobic exercise will be classified as running, cycling, swimming. They're very similar in terms of inducing cardiovascular outcomes and metabolic outcomes. Now, you mentioned about circuit.
Yeah, well, which is the best? I mean, like a setting for Wimbledon, who's 1, 2, 3, 4.
Resistance training, circuit training, doing weights, it's probably, it's very important. I think it will be depend case by case. But someone with very low muscle, it's likely to benefit more from resistance training. Then they will be able to graduate and go for a walking program. So ideally, and that's the recommendations that we have, it's the combination of aerobic training and resistance training. It's the combination of the two. It's hard to call which one's the best.
What's the best out of walking, swimming and running?
Well, not everybody can run, for instance. Everybody can walk. Running is certainly a progression of walking. You can increase the intensity and it will lead to additional adaptations. Swimming is also interesting, but it's a cardiovascular training. You won't build muscle swimming. It's an endurance activity. And when you spend a lot of time swimming, you can actually lose bone mineral density. This is for athletes. So, but overall, those are all three good aerobic exercise programs or exercise modalities.
Thank you.
I just want to make a comment on that last question from my experience in the Solaris Foundation and as a cancer clinician, and I supervise a PhD student at UWA in this area as well. And I think the key message that the literature supports, and which Daniel has said very well, is that walking isn't enough. And a lot of cancer patients, in addition to the anorexia, chemo is very catabolic. Steroids are very catabolic, cause a proximal myopathy. I've had patients still feeling fatigued 2 years after chemotherapy who've been walking religiously. You change them over to a resistance training program and 4 weeks later they feel like they're getting back to normal at last. And you need the resistance training to restore muscle mass, which is the key way to circumvent the fatigue that's such a problem for cancer patients.
So it's not either or, it's both?
Yes. Walking on its own isn't enough.
That's a very good point, David. And for instance, for prostate cancer patients undergoing hormone treatment, resistance training will certainly be the best exercise modality as well.
Professor, could you just clarify what you mean by resistance training? I'm getting the impression you're meaning weights training.
Yes, it's weight training.
I would have thought something like running is in fact a resistance training as well, because each step you take with running, you're actually pounding 4 times your body mass through each leg. Yeah. So you're actually doing a resistance training when you run.
It's more endurance training. Resistance training will be a stimulus that you can apply to the muscle. You could lift a weight up to 12 times and you feel fatigue. When you're running, how many repetitions are you doing? 1,000 repetitions for the quadricep muscle. So the stimulus is more of resistance, of endurance, not strength and gain of muscle hypertrophy. Hypertrophy, you only achieve hypertrophy with moderate to high intensity resistance training. For instance, if I'm lifting these miles here 50 times, I won't get stronger. If I lift 15 kilos 6 times, I will get stronger. So it's a different stimulus to the muscle. Thanks.